appreciate it very much. We have so many people. We couldn't hold this event at the Bipartisan Policy Center as we normally do, so thank you all for coming out. I'm Bill Hoagland, I'm Senior Vice President and at the Center, and I have the honor and pleasure and sometimes frustration, but of overseeing the work at the Bipartisan Policy Centers on health, with our health team. About a year and a half ago, the Bipartisan Policy Center launched an initiative, and we called it the Future of Healthcare. And we were able to secure the participation of 10 nationally recognized, well-known healthcare policy experts, 5 Republicans and 5 Democrats, to launch this venture. And the goal was to see if we could find some common ground in this public policy arena as it relates to access, cost, and of course the quality of care delivered. The 4 co-chairs of the group, and I dub it the Big Ten, are Senators Tom Daschle and my last boss on Capitol Hill, Dr. Bill Frist, Andy Slavitt, and Gail Walensky. They, along with Avik Roy, Jim Capretta, Chris Jennings, Sheila Burke, Alice Rivlin, and Cindy Mann, have worked together in a bipartisan manner to address these issues impacting healthcare in the future. And maybe somewhat amazing at times to me, but on this subject matter that's so charged with partisanship, that we've been able to keep the band together over the last year and a half. And I think that speaks well to the co-chairs' leadership on the Big Ten and the recognition by them, I think all of them, that any long-term sustainable health policy reform must be done in a bipartisan manner. The Big Ten group has also benefited from the Bipartisan Policy Center's Governor's Council's input, as well as a newly formed Health Systems CEO Council. Most recently, the group labored in the health policy vineyards by identifying and promoting a set of policies that we thought would help stabilize the private health insurance market. Last fall, following the legislative defeat of the repeal and replace, they put forth a set of consensus recommendations to stabilize the individual market. Those recommendations came close to, but not, unfortunately, to being enacted. They failed to make it across the closing line there in Congress, once again over what turned out to be some very sensitive and strict partisan divides. So today we have 3 agenda items we want to go through with you and cover before we open it up for your questions to them. First, Senator Daschle is, as one of the co-chairs of the Big Ten, will briefly discuss the statement of common understanding the experts have agreed to post the failure of the final agreement last year in the session of Congress. That statement, along with the second agenda item, which will help us guide our deliberations and content on specific policy recommendations going forward. Following Senator Daschle's comments, Morning Consult staff will review the results of a national survey that we conducted earlier this month, focusing on the public's attitudes on costs and coverage, including the continuum from a single-payer system to a fully private market system. By the way, other issues were included in that survey, but given the time constraints, we're not going to be able to go through all those issues, and so we have posted this morning on our website the full survey results of all the questions were asked. And finally, our esteemed BPC President, Jason Grumet, will finish off by moderating a discussion with, we had hoped to have 5, one of them, Avik Roy, has had travel problems this morning, so we'll have 4 of the Big Ten, including Chairman Daschle, to discuss the survey results and the outlook for bipartisan solutions, the challenges, and the outlook for the future of healthcare policy going forward. So without any further ado, Senator Daschle.
Thank you very much, Bill. On behalf of all of my colleagues participating in the BPC's Future of Healthcare panel, I want to welcome you and thank you for being here today and for watching the broadcast on the event. I'd also like to especially thank the Robert Wood Johnson Foundation for making all of this work possible. They've just been a remarkable partner on so many projects relating to health, and this is clearly one of those prime examples of just the enormous partnership that we've appreciated with them for a long time. I also want to note that some of my colleagues, as Bill noted, were not able to be with us today, and they include my friend and former colleague Bill Frist, former Healthcare Financing Administrator Gail Walensky, former Congressional Budget Office Director Alice Rivlin, former Acting Center for Medicare and Medicaid Administrator Andy Slavitt, and former Director of Center for Medicaid and State Operations at CMS, Cindy Mann. Bill mentioned Abbott was unable to come as a result of some travel issues, but we want to wish Gail, in particular, a happy 50th wedding anniversary, which is why she isn't here today, and certainly want to wish Alice Rivlin a speedy recovery. We believe it's critical to end the negative discourse on health care in this country. Rather than simply criticizing each other's ideas, our hope is that we could start listening to one another to gain a better understanding of where colleagues across the aisle may be coming from, and encourage members of Congress, those in government, and those engaged in this dialogue and this debate the same. It's important not only in the area of health care, of course, but in a broad range of issues that divide our country today. This morning, we're releasing our Statement of Common Understanding on necessary principles for reaching a middle ground on health care. And though they are broad, believe me, they were hard fought. You all have the detailed copy of them in your materials, so I will focus on just the high points. Number one, all individuals should have meaningful, affordable, public or private health insurance. 2, health reform should be designed to avoid major disruption because many patients rely on today's long-standing arrangements to get needed care. 3, insurance markets should be stable, not endangered by premium increases due to adverse selection or insufficient pooling of risk. 4, health reform should reduce excessive and unnecessary health care cost growth. And 5, reform policies must be politically and financially sustainable over the long term. We know they're not perfect, they're not all-encompassing, but we do hope that they can serve as a starting point for us to begin to dig down and find common ground on the details around each one of these points. We're also hopeful that our efforts will prove helpful to others at the federal, state, and local levels in finding that path forward. Thank you again for joining us, and I look forward to the discussion this morning.
Hi, everybody. Thanks so much to the Bipartisan Policy Center for inviting us to be here. My name is Chris Doty. I'm Director of Client Services and Polling at Morning Consult. Morning Consult is a technology, media, and research company here in DC, and we partnered with the Bipartisan Policy Center to run a demographically representative study of 2,200 Americans on their perceptions around the future of healthcare. So today I'm going to walk you through some of this data and let you know where Americans see where the bipartisan path leads. If my clicker can work. All right, so we have 3 topic areas we're going to go through today. The first is going to be healthcare priorities. This is a more general topic, starting really broad with American perceptions and getting more down into the actual details later. So the first question we asked respondents was to evaluate whether they support or oppose bipartisan efforts and compromise on healthcare reform. Here we can see that around 48% of respondents in total say that they support bipartisan efforts and compromise on healthcare reform. That's strong and extends across the partisan divide, Democrats and Republicans agreeing similarly. The key takeaway here as well is that the percentage of those saying that they disagreed, that they actually opposed bipartisan efforts, are very low compared to those saying that they support the efforts. So there's much stronger support than opposition. Second, we got into some of the more general ideas about what Congress's priorities should be for in healthcare reform space. In this, we see that Democrats largely are concerned with providing access to all Americans. We see that that's the top answer choice overall, but mostly driven by that Democratic support. Republicans, meanwhile, are primarily interested in lowering costs and in limiting government involvement in the healthcare space, with about a quarter responding to each of those answer choices. Next, we looked at the costs, obviously, and in here we asked both on a micro level whether respondents agreed or disagreed that individuals and families pay too much for healthcare, and on a more macro level, whether overall Americans spend too much on healthcare. Here we see the strongest agreement across party lines. Americans agree that both individuals and families pay too much, and overall, Americans in general pay too much for healthcare. Here we see that around 85%, nearing 90%, agree on the individual level, and then overall, again, 80% agreeing. The second topic area that we're going to cover is finding common ground on healthcare policies. So this is where we get into some of the more bipartisan issues and checking in on some of where there's support across the aisle on this. So the first question that we asked respondents in this section was a dichotomy on whether they supported a more federal government-involved approach or a more market-driven approach. So here you'll see the federal government-involved approach in purple versus the more market-driven approach in green. And you can see that in total, 48%, nearly a majority, supported the market-driven approach when given this dichotomy versus 39% saying that they supported the more federal government-involved approach. Interestingly, we see some bipartisan carryover here as well. So we see that 46% of the non-liberal Democrats in this case actually support the market-driven approach rather than the federal government-involved approach, which shows that there is some level of bipartisan support for that market-driven approach. While there is more support for the market-driven approach rather than the more government-involved approach, when we asked some specifics, so what approach to changing healthcare in America are you most comfortable with, we see that when given an option of reforming the ACA, which includes lowering premiums and ensuring cost-sharing reductions, more Americans are actually likely to support that rather than the specific market-driven approach. The difference is rather minimal, so just an 8% difference between those two. But the reformation of the ACA is the top of people's lists. Falling down lower than this include both a single-payer system and privatizing the insurance industry, or the market generally, including Medicare and Medicaid. Next, we looked at some of the general approaches to the market-driven approach and the single-payer approach. We looked at some of the specifics of how these would be implemented, and we're asked respondents how willing they were to accept these things in each of these. So on this slide, we're looking at market-driven approaches, and in the next slide, we'll take a look at the single-payer. So here, we're seeing that rising to the top are some of the core tenets of a market-driven approach. So personal responsibility, a full reliance on competition and markets, those sorts of core market-driven attributes really resonate with respondents, with around a majority responding positively. It's being willing to accept a market-driven approach to healthcare given those. Where we see things falling to the bottom here with significantly less support and willingness to go along with a market-driven approach relate to some of the cost implications, especially on a personal level. So here we see permission for giving health insurance companies to set deductibles to up to $10,000 at the lowest level of support. along with requirements that everyone but the very poor contributing to health insurance premium, and less regulation of health insurance plans, which could mean fewer required benefits and higher premiums for those that are elderly or less healthy. We asked a similar question about the single-payer universal healthcare system. So how willing would respondents be to support a universal single healthcare system in the U.S. Run by the U.S. government that ensured that every person had healthcare coverage with lower out-of-pocket costs? Here, again, we see cost implications tend to lower people's willingness to accept these. So we see increases by taxes of $50 a month would drop willingness to support the universal system quite a bit, down to 39%. And increasing the taxes up to $100 a month drops it far lower. The personal cost implications in this case also drive the top priority here. So government setting price limits for healthcare providers and drug manufacturers to constrain program costs, significant levels of support for that given the universal healthcare system. So again, personal cost implications all the way throughout this data. And speaking to that, we'll move into the third topic section, which involves how the government could respond to controlling healthcare costs. We gave respondents a significant aid here, which asked them to read a topic and a description on some of the government healthcare programs. So we asked respondents to evaluate the statement that the federal spending for programs such as Medicare, Medicaid, CHIP, and health insurance subsidies programs were expected to double in the next 10 years to $2 trillion, mostly due to the rising cost of healthcare and an aging population, along with an aid saying that the Medicare program is expected to run out of money within the next 8 years, expected to not be able to pay for all of the necessary healthcare costs for people enrolled in the program. So given that description, we then presented respondents with a list of 12 different options and asked them to rate how, if they believed that the government should take these actions in order to help with these programs. Over the next 3 slides, we'll see a list of all of them. On the first slide, this is the top options, and you'll see in the box, most of these options, again, relate back to some of the personal costs. So whether that's increasing the government's role in setting prices for healthcare goods and services, increasing taxes on certain goods such as tobacco, sugar, beverages, and medical marijuana, increasing the government's role in establishing payment systems for healthcare providers, and increasing the government's role in promoting lower prices for healthcare goods and services. All of these, some of the top choices really relate to respondents' personal expenditures in the healthcare space. When we look at some of the middle tier sort of options, so these are significantly lower in terms of acceptance by respondents compared to the others, but still some levels of support. You can see here some of the more conventional ways that the government could control costs, such as cutting benefits or raising consumer costs here, have considerably less support. We see that having the private sector takeover of the healthcare has considerably less support at just 13% support overall, with a somewhat higher level of support among Republicans. And raising the age of eligibility for Medicare from 65 to 67 also has a considerably lower level of support than some of the personal cost. And finally, these are sort of the no-go options for Americans that we surveyed. These are sort of the options that fall way to the bottom. So in these, few people are willing to embrace a tax increase. So just 1 in 10 people say that they're willing to embrace a tax increase in order to fund these programs. They're much more interested in the government providing those cost controls that we saw on the first slide. And similarly, they are also extremely reticent to look for reduced benefits as covered under Medicare. So with that, that's the presentation. Thank you very much.
Thank you very much, Chris. I appreciate it. My name is Catherine Hayes. I'm the Health Policy Director at BPC, and what I would like to do is invite our panelists to come forward as I not as I introduce them. Please come forward. First of all, moderating will be Jason Grumet, founder and president of BPC. He is respected on both sides of the aisle for his innovative approach to improving government effectiveness. His first book, City of Rivals, Restoring the Glorious Mess of American Democracy, was released in September of 2014. Our panelists include, and all of them members of our Future of Healthcare group, Senator Tom Daschle, a BPC co-founder who co-chairs the Health Project along with former Senate Majority Leader Bill Frist. He served as minority and majority leader from 1995 to 2005. Senator Daschle is the founder and chairman of the Daschle Group, a public policy advisory of Baker Donelson, where he provides strategic advice on key national issues. Sheila Burke is a fellow at the Bipartisan Policy Center. She chairs the Federal Public Policy Group at Baker Donelson in Washington, D.C. She is a faculty research fellow at the Malcolm Weiner Center for Social Policy and faculty at the John F. Kennedy School of Government at Harvard University. Sheila served as chief of staff to Senator Bob Dole from 1986 to 1996 when he was Senate Majority and Minority Leader. In 1995, she was elected Secretary of the Senate, the body's chief administrative officer. We have Jim Capretta. Jim advises BPC on the Health Project, is a resident fellow, and holds the Milton Friedman Chair at the American Enterprise Institute, where he studies healthcare, entitlement, and U.S. budget policy, as well as global trends in aging, health, and retirement programs. Jim served as a senior health policy analyst at the U.S. Senate Budget Committee and the U.S. House Committee on Ways and Means, and was also associate director at the White House Office of Management and Budget. Finally, Chris Jennings. Chris is president of Jennings Policy Strategies, a Bipartisan Policy Center fellow. He has over 3 decades of health policy experience, serving in 2 White Houses, the Obama and Clinton White Houses, Congress, and the private sector. Chris served as a policy advisor to the president for health policy and coordinator of health reform in the Obama administration, and in a similar capacity in the Clinton administration. Thank you all very much for joining us today.
Thank you, Catherine. And so we're actually on time, which is kind of remarkable, especially if we have a senator opening things up. And so we're going to take advantage of that, have a conversation with the group here, and then obviously have a lot of time, hopefully, for some interaction. As I hope many of you know, the kind of core of the Bipartisan Policy Center's imagination is productive partisanship. We are not post-partisan or non-partisan. We actually believe in the constructive collision of principled folks who are passionate about their views and willing to work together. And one thing about the health debate, I know most of you are deeply involved, there's lots of productive conversations in private. And so we're going to try the outrageous act of having a productive conversation in public and hope that that might actually stimulate more of the same. And I'd just like to kind of level set, think a little bit about just kind of the philosophical underpinnings of this brawl, because there's a lot of focus on policy mechanisms we'll get into. There's obviously a lot of politics and almost existential tribalism, but at the core of this debate, there really are some very fundamental beliefs about the role of government and the role of healthcare in people's lives. And I guess I wonder maybe, Tom, if you would start off, just how do you frame kind of the philosophical view that is kind of core to the democratic healthcare worldview?
Well, I think, first of all, that there is a real debate in the country that's been going on for over a century over what the role of government should be. And I think at its core, that really is the essence of the difference between Republicans and Democrats. We generally believe that there's a cost problem, there's a quality problem, there's an access problem. We generally set as our goal a high performance, high value healthcare marketplace with better access, better quality, and lower costs. The real question is, what is the role of government in getting there? I think most Democrats would argue that government can play a very important role. We have a $3 trillion public-private partnership in our country today when it comes to healthcare. There has been an integration of the roles of government and in the private sector. I don't think we've done it very well. I don't think we have a system today as much as we have a collage of subsystems, both public and private, and that works to our advantage as well as our detriment. And I think what most Democrats would say is that there has to be a framework And that framework largely comes from the regulatory and statutory ability of government to set out the architecture for good health care today.
We're gonna drill down a little bit, but Jim, recognizing that all Republicans think exactly alike these days, how would you frame the Republican philosophical worldview?
Well, I'd probably be very low on their list of nominees to speak for all Republicans, but anyway, I'll give it a shot. I'd say that, from a conservative perspective, the country's history is very, very obviously driven a lot by our constitutional structure. And so there's what I view would be fairly healthy skepticism that our system of governance, which is built around checks and balances and limited ability to act quickly, doesn't lend itself to running a health system centrally that well. And so they don't articulate it quite that way, but there's a sort of sense that our constitutional structure was intended to decentralize decision-making for big, complex systems like healthcare. And that doesn't rule out, of course, that the political process wouldn't have some role in providing oversight and some framework to it. But the idea of it totally being, or gradually even being moved toward more centralized control does raise a lot of people's concerns about what that would end up looking like. The United States is different than a lot of other countries in a lot of ways, but one of them being that there is dispersion of political power. And so it makes it very difficult for a single executive to run something because there are lots of checks on that executive's ability to do so. Mm-hmm. And we like that in most walks of our life, in America, but in healthcare, that may have challenges. And so I think some of it is, again, back to the role of government. What does our Constitution allow for the government to get involved with? What should it be more constrained in being involved with? A lot of the, energy on the conservative side kind of comes up from that point of view.
So Sheila and Chris, we're going to talk about the poll quite a bit, but I think one of the shocking takeaways is that when actually people drill down a little bit, the notion of an all-government or a no-government system, in fact, doesn't appeal to either Democrats or Republicans. I mean, how do you see that fitting into this kind of philosophical framework?
I mean, I think it underscores both what Senator Daschle has said and what Jim has said. I mean, I think there are, and have been for years, deep divisions over the sort of role between the government and individual markets. And I think we do have a system that is quite mixed for a variety of reasons. It is, as Senator Daschle suggests, not a system. It is a series of moving parts. The history, not only with the federal government, but also with the role of the states, I think, which has become increasingly obvious to us in the course of the discussion over the last few years in terms of their view as to what role they should play in terms of the service delivery and financing of care in their own states. So I think it does come down to the basic question as to whether the government sets up a framework and then people play within the framework, or whether the government essentially takes over the full controlling role. And I think the polling results suggest to us that people are very deeply divided over that fundamental question. And I think what we see today in terms of the mixture of the systems reflects that confusion. I mean, our system having really come out of post-World War II in terms of the development of private insurance and the role of private insurance, the development of the public finance programs, Medicare and Medicaid, each of those has moved us in an interesting direction in terms of what that role looks like. And so I think, again, the issues that have been raised are exactly on point in terms of why it is such a difficult thing to come to closure on.
Chris, you've always struck me as a philosophical person. Anything you'd like to...
I have no choice. I guess I'd say that, you look at this poll and you kind of say, well, that's helpful. Policymakers, go fix it. And I think the real takeaway right now of where the public is they're very frustrated with cost and affordability. They're not so certain about the best approach to secure that outcome. Indeed, they're skeptical, and they're also skeptical if cost interventions are going to lead to more cost for them. There's a difference in the issue of affordability for the government and affordability for people sometimes, and so we really have to get beneath that, because if you're really talking to people, they're talking about what their costs are. So you saw that poll on premiums and out-of-pocket costs. You have to combine those two because people think of them both as their cost. From a Democratic perspective, philosophical perspective, I guess I believe that most Democrats believe that health care is a basic human need that is necessary for all people to achieve their greatest potential. That's basically it. And if you start with that, you can't look at our current system and say that we have delivered on that. And I don't think people care so much about the policy prescription as they care about the outcomes. Mm-hmm. And it's really up to policymakers to start delivering on outcomes as opposed to specific approaches. And the last thing I'll just say, just my takeaway from the poll a bit, was this reference to markets. I'm for markets, except I'm opposed to market-oriented approaches, So, it's a very, you have to be a little bit sympathetic to the confusion policymakers have on what guidance am I given, what trade-offs are the public willing to make to achieve the outcomes that they desire. So all these things are, I think, the reason why we continue to struggle to achieve complete consensus on the best prescription to achieve those desired outcomes.
So I want to talk a little bit about our process before we get into more of the substance. I think it is an understatement to acknowledge that the political discussion has been somewhat dysfunctional over the last forever. And we were able to convince 10 of you who have day jobs and other hobbies to spend what has literally been hundreds of hours in a process that has been at times uplifting and at times somewhat frustrating, trying to really see if we could hammer out specific details. And maybe this isn't a question that I should ask in public, but why have you all been willing to do that? And what do you see is the value of this exercise as it might influence the more public discussion?
Beyond that we're masochists?
Just jump in, yeah.
I guess I would reflect on my former boss, Bob Dole, who turned 95 this week. I would note, and Senator Daschle had the opportunity to chat with him for his birthday, as did I. Dole's view was always to look at a problem and then try and find the answer. In some respects, he was a classic legislator in terms of, if there's a problem, there's got to be a solution. The Social Security example is a good one where he and Pat Moynihan, at the last minute when things were falling apart, essentially came together to pull the Greenspan Commission and that work out to achieve a solution. I think it is the thought that there has got to be an answer, and the only way to find it is to find some middle ground, that there will neither be a completely conservative answer nor a completely liberal answer, but somewhere in the middle there has to be a solution. And it is a problem that is so clear and so much at the heart of what we care about in terms of a society. I think it was time well spent.
I'm motivated, Jason, because I believe that in Washington right now, people view compromise as capitulation. And I'm very deeply concerned about that attitude. I think compromise is the oxygen of democracy. If we don't have compromise, we will starve this democracy as we look at the challenges we face in public policy today. So what we've articulated in this compromise document is not what I aspire to, but it's what I agree to in terms of moving public policy forward on health care. It is remarkably contentious, and even with 10 people of goodwill who really have great, I would even say, affection, certainly admiration for one another, this was very, very difficult. So it, again, is unless you've experienced it, you can't even articulate how difficult this has been just to get to this. But I think that essence of dialogue is so critical in the process of reaching compromise. And if we can demonstrate that it is still possible, then I think we've contributed something.
So a lot of our aspiration is that kind of existence proof of the possible, not that we're providing the precise outcome. But I would like to go behind the music a little bit and unpack these principles. when you read them, they seem incredibly obvious. Less obvious is that we probably went through maybe 100 versions. I mean, I at one point in the middle looked at the red line document, and it actually looked like a kind of a redacted FISA document. The only words left in black were the conjunctions. And so, talk a little bit about why what maybe seemed like these somewhat obvious principles, what was so hard about them? Where are the tension points that we'd like people to at least understand caused the real challenge?
Well, I guess I'll jump in here. I guess the document, one could read it, and then you read it, and you're immediately thinking about policies that might flow from it, right? And so one person reads it, and they imagine certain policies flowing from the statement, and another person reads it and imagines a different set of policies, and maybe they equally oppose the other person's view of what might be said by it. And so some of the tension points really are looking ahead to a more difficult round, which we'll all have to engage in, which is, what does it mean exactly, And so I think, obviously, there's deep divisions here. And I just want to go back a little bit to the previous question, just make one point, which is that I think the public is very frustrated by what Senator Daschle put his finger on, which is the lack of oxygen in democracy, the lack of compromise. Basically, the public, whenever there's a big compromise where 60 or 70% of the Congress sort of gets behind something and it passes, there's generally kind of a sigh of relief, usually, that follows for a few years. And people say, okay, finally, they agreed on something. It looks like more, because it takes the energy away from the partisans who are trying to hold back compromise, because basically reasonable people say, well, let's compromise, let's get this thing done, let's move on. There hasn't been enough of that for about 20 years or so, 25 years. And so lots of things are building up with, dysfunction and tension. And either side, when they're in power, sort of grab what they can, but it's not enduring because it isn't accepted by the other side. I think you can go down a list of a lot of policy areas where that's occurring. And so I do agree that our constitutional structure pushes people to compromise, and they're just not doing it enough on a lot of levels. And so, and healthcare is probably, one or two or three on that list.
Yeah, I just wanted to say that part of this moment where we came together is also, I think, a reflection of our perception that we are a very divided country. We don't see a lot of hope in the immediate future where there's going to be a swing too far one way, too far the other way. We'll see what happens in this election cycle. But even now, it's a very close dynamic, and after this election cycle, it might even be more split. You can't get anything done in a split government if you don't compromise. That's a really important point. And if you look at the next few years, that's what we're talking about. Point two is, if you accept that as a proposition, then you can either say, let's go back to our little sides and fight it out and really essentially achieve nothing, while people are still waiting and wondering why you aren't responding to need, or you try. That's point two. And point three is, and this has been very frustrating for someone like me to see, but and even perplexing beyond comprehension sometimes, which is that a solely perceived to be partisan approach, whether we can debate whether it was or wasn't the Affordable Care Act, but perception is very hard to sustain as you implement the law and then work towards improving it. And so for all those reasons, I just want to give some context as to why those of us who have been in these rooms for 10, 20, 30 more years have decided to come together to at least attempt to come up with a framework that can create the foundation for a possible policy compromise going forward.
So, we always project that the end of the toxicity is near. And I think we're trying to be in a position where we've presented ideas that, in fact, then at that moment, because those moments don't last for a long time, that we'll be ready for it. One of the key tools at the BPC in achieving compromise is exhaustion. That after a certain amount of time, the energy for the fight seeps out and kind of a collective evidence-based truth, if you can use that word, kind of floats up. And Sheila, you're very close to the political process. I think, do you have any sense that the fever of the ACA repeal debate is cresting, or do you think this is just going to be a perpetual political motion machine?
Well, it's a hard one. My instincts would suggest that, in fact, it is beginning to wane, and we are beginning to see some attempt to try and find solutions to some of the issues that have arisen as a result of the ACA and its structure. I mean, this morning we saw from last night's announcement the reinstatement of the risk adjustment payments. I mean, as a piece. But you can't help but watch the sort of activities in the House and the Senate. And there is still a residual opposition to the fundamentals of the ACA and a continued attempt to try and get at the core of the ACA through a variety of things, whether it's the marketing money, whether it was the risk adjustment payments, a whole series of questions. So I'd like to say that yes, it has begun to wane. I think the midterms will be an interesting thing to watch because some of that opposition tends to come out of the House rather than the Senate, where you've seen less willingness to sort of continue to go back to that basic question of repeal. But again, I think we don't yet know the answer to that question. I think it's still playing out in a lot of different ways. Certainly the regulatory process and other tools that are available to the administration would suggest that there's a continued attempt to essentially alter it. The whole waiver process, how the states are responding in a variety of ways with respect to the Medicaid expansion and other issues. So I think the answer is mixed.
So before we kind of move on to some of the polling questions, let's just dig a little deeper on policy. So recognizing, I think, the agreement that I know you all have with Chris that we're going to have a closely divided government for the foreseeable future, where do you see the space where either one or the other parties has kind of a key issue or ideas that have that potential to generate 60 or 70%? If the imagination is that you take your victim as you find it, right? This is the kind of, we are not going to fundamentally reshape the boundaries of our healthcare system in the next few years. What can be done to bring more stability, more predictability, lower costs to the system?
Well, I don't think there's going to be a single thing that will occur. I think something Sheila just mentioned is worth emphasizing, and that is the more dysfunctional Washington is, the more likely it is states are going to pick up the difference. And I think you're going to see continued efforts at innovation and real leadership in healthcare at the state level in many cases. And I'm actually encouraged by that. I look at some of the states and the things they're doing across the board, and I'm encouraged that there seems to be a willingness on the part of state legislators, state governors to pick up the slack and to begin to address these things. But it's going to continue to be around those three primary challenges: cost, access, and quality. Cost is, as the polls indicate, by far the most important. And what we've seen in research in the last couple of years especially is that we're seeing increases in cost in part because of lack of transparency, which I think is one of the biggest challenges. So anything we can do to advance transparency is helpful. But in addition to that, I think it's not overutilization. We don't utilize our healthcare system any more than other countries, but we have higher prices for every single procedure and every single experience in healthcare, much higher prices than anybody else. And I think we've got to look at price as one of those factors that will have to be addressed through public policy.
And Senator, you remind me that one of our more ambitious efforts in recent years was when you and Speaker Gingrich got together looking at this question of state flexibility and waivers. And I seem to remember you had the notion of kind of flexibility with guardrails.
Right.
How do you, where do you see the state innovation? And I know it's hard to predict exactly how these waivers get addressed, but do you believe that there's going to be more experimentation tolerated? And how do you, what do you see as the pros and cons of that dynamic?
Well, if you're asking me, I would, given the state of affairs in Washington, I don't see any reason why we shouldn't encourage states to be out there as experimenters and as the laboratories of innovation. And some states are going to do it better than others based on resources and need and leadership. Leadership varies dramatically from one place to the other. But I think that it's all good. I do worry about the even further fragmentation of a non-system like we have, and we're fragmented extensively today in so many different ways. But I do think that that fragmentation is worth the risk if we can move the innovation and if we can find ways to begin to address these challenges, both through public policy and innovative private sector concepts that have yet to be developed.
Jim, if I were to roll you the 10th Amendment, what would you add?
Well, I just want to agree, though, that the opportunity for some bipartisanship really may be at the national level, maybe, hey, let's agree to allow the states to have some flexibility within guardrails. And I think you might get some Republicans and Democrats saying, given the disagreements at the national level, why not let that happen more? And then, you might see as particularly Republican governors grapple with the reality of administering on-the-ground programs at the states, they tend to be a little bit less ideological just because they got to make the trains run on time. And in that regard, they can work with some of the structure of the ACA and put their own stamp on it. The exchanges, President Obama liked to remind us many times that it was a Republican idea, right? So I don't want to get into all that history, but there's an element there of potential consumer choice and market competition if it's done right. And a Republican governor who's creative could take that structure and work with it and put his or her stamp on it to make it more market-oriented, make it more consumer-driven. And at the national level, maybe they do try to make it easier for some people to pay for the big deductibles that they're facing by attaching ability to have HSAs with them and so on. So, you can see elements of using the ACA structure at the state level to maybe have even some Republican governors pick it up and work with it.
Well, I just want to say that one of the advantages of having done this for decades is that you see cycles, and usually, and we saw this actually, Senator, at the end of the late 80s, there was a big movement to do state-based health reform. In fact, I worked for a boss who introduced legislation right before Bill Clinton said, no, let's do it a national policy. That was sort of an interesting, since we're both from Arkansas, but that's another story. But the issue was that there was great frustration with the federal government's inability to respond. And so that's what occurred. What I suspect would happen under this type of scenario where we do provide more state flexibility is that good and bad things will happen. And at some point, the states will realize that there are big federal barriers to doing everything that they want to do. And then they'll come back to the federal government and say, we need to have a system that works. Some people are willing to roll that dice. Some people aren't willing to roll the dice. It has a lot to do with trust, and that gets to the issue of the definition of the guardrails. I will say I'm encouraged. Just yesterday, Governor Haslam, who's from Tennessee, which is an extraordinarily red state, one of our first sponsors of BPC was from Senator Baker, but this state has become very, very red. But he said that he was thinking that we should move towards expanding the Medicaid program under the Affordable Care Act. Now, of course, he's leaving office, and thank you. But it's an important signal, it seems to me, that we're seeing more red states contemplate expansions, and I think that's an encouraging development, and that is obviously a state-based development.
One of the, something that's not new, but what we've struggled with for years is that when you see one state Medicaid program, you see one state Medicaid program. The fact that there are enormous differences between the states has always been the case. And it's been true both on the public side in terms of the structure of the Medicaid program and its coverage policies, because the states have been given traditionally a fair amount of flexibility. But it's also been true in the private market. And the availability of coverage and the structure of coverage in the Dakotas is very different than it is in California or New York or Illinois. And the reality is the governors are having to confront those questions. How do I make sure there's an insurer offering coverage in a particular county? How am I dealing with the number of people who are uninsured? I mean, Texas has one set of issues. They're different than the issues that are being faced in Arkansas. So I think the reality is the governors have had to, for the reasons Jim suggests, had to get at the question of how do we solve the problem for our population, and given our resources. Because the state's capacity in terms of financing these programs, I mean, the age-old strategy behind the Medicaid match rate was a function of testing the state's capacity to finance. That's the way the match was structured. So again, I think these are issues that we've confronted for a very long time, and the states have been very innovative. But there are risks. I mean, this question of guardrails is one that we as a group have talked about. I mean, what is it that you would suggest are the limits to that flexibility, if there are to be limits, or do you allow essentially full experimentation to occur on the public side with the public finance programs and on the private side in terms of the structure of their private insurance market and what the rules are for the private insurance market. But the governors are very close to the reality. When the premiums are going up, when they don't have somebody to provide coverage in a particular county, Mississippi's gone through periods of time where they've had no coverage in certain counties. It is a huge issue for a governor. So they are much more likely, because they are so close to the situation, to look for solutions that will be tolerated in that community. And I think that's what we've begun to see. And that's what led to a lot of the innovation.
So, as we think also about looking forward, while the debate has been rather stuck, the world continues to move. And, I think one of the points of some political optimism is that a new set of issues is now really starting to dominate the discussion. The integration of behavioral and mental health is a priority that we have been spending a lot of time thinking about. The opioid crisis has now really become, in many ways, the national narrative about our healthcare system. We're looking at challenges unique to rural America. Do you think that some of those issues could start to transcend the old debate and just kind of retool ways and coalitions and that might in fact improve upon the overall quality discussion? And where would you point to as a focal point for the next 4 or 5 years?
Well, some of those issues, I think, behavioral health and the integration is one that's fairly fundamental to the delivery system writ large, and is being tested out in lots of different ways in different communities given the demand and need. So I think that is an issue that will supersede any politics because, in fact, it is such a compelling issue to try and figure that out. And it's an issue for healthcare providers to figure out how you integrate those systems. Opioids is another good example where rural communities, the sort of center of the country, places like Indiana and Ohio, and up in the Northeast in Vermont and New Hampshire and others are faced with huge issues in terms of service delivery as well as dealing with interdiction issues. And so I think it is an opportunity for a coming together. I'm not sure it overcomes the sort of other questions, but it's certainly an opportunity.
Yeah. And I just say, interestingly, in the debate around repeal, replace, probably the most salient discussion amongst conservative Democrats and moderate Republicans were, if I cut and slash Medicaid excessively, I will not be able to have an infrastructure for the prevention of and care for people who have opioid challenges and also mental health. I mean, our mental health care system is essentially, just like our long-term care system is essentially our Medicaid program. So at some point, we have to recognize that we keep on, a lot of us at the federal level keep on pushing this back down. You guys take care of it, and the states will say, fine, but give me the resources. And then we'll say, fine, but if we're giving you the resources, don't do bad things. And that becomes the 10th Amendment federalism challenge.
I think one of the great things about our democracy is that every 2 years there's an election, I think for good or ill. And so whatever the concerns are that are motivating the public, politicians are pretty good at figuring out what really is driving people at that particular moment. And so new concerns come into the Congress that perhaps weren't from previous election cycles. And so whatever it is that's bothering people tends to be reflected in the new class of people and all the people that are running for re-election, and they come back saying, here's what I need to deal with. And so I think you're right. New issues do come up, and some things feel a little bit like fighting the last war instead of looking ahead to what really is going to be coming next. And so, I'm not really sure exactly what that means in terms of the issue list you came up with, but one backdrop we have right now is the economy is fairly strong, and so it is a good time to take on some of these things. I mean, we're in a better position than we would have been perhaps, during 5 years ago when things were still struggling out of the financial crisis. People are in a better position, and we can take on some of these things that I think need to be addressed.
I think there are a lot of categories of potential areas for further compromise. I think there's still a growing recognition that value-driven care is something that both conservatives and progressives can endorse. I think it's a question of how one defines value and calculates it. We have never been able to get our arms around quality measurement effectively, but people are generally aware that fee-for-service has rewarded volume, rewarded price, and we haven't really found the alternative to fee-for-service to the extent that we can address a meaningful movement away from it. But it centers around finding ways to assess value. I think social determinants are also rising to a higher level of appreciation. We're beginning to understand the importance of social determinants and the need to address them early in life. Chris said something in his opening comments that I think ought to be amplified. As Democrats look at really the basic challenges we face in any society, the two most empowering things we can do for everybody is health and education, our health and education. I mean, the more we can provide the best opportunity for a good education and the best opportunity for good health, the more we're going to empower every individual. Well, how do you do that? Well, I think social determinants around health are one of those criteria by which we measure the potential for improving access to better health.
I will note that our BPC new Higher Education Affordability and Accountability Task Force is meeting at 13th and I Street as we speak, so we'll hopefully be able to do the double header on this one today. I want to ask a couple of questions about the survey and then open it up for a conversation, so fair warning, in about 5 minutes. Hopefully we'll have time for a bunch of questions. And when I looked at the survey, one thing I was pleased is that we really kind of probed this kind of theory versus practice. I saw a survey once which said that 90% of the American public wanted more infrastructure investment and 95% wanted to prevent any projects in their neighborhood. There was a great survey when they tried to build a subway in LA. About 85% of the people in LA strongly supported the metro. 3% said they were going to use it. In this survey, there was profound support for cost containment, except when we talked about any of the actual specific ways one could contain costs, and then that support withered to 10 or 15%. How do you, did that strike you as well? And what do you think will it take to get the policies to actually reflect that broad shared imagination for reducing what you point out as just the unrealistically high costs?
Well, can I just say one thing about that? Because that, to me, was the most striking part of the whole survey. It wasn't just that people are frustrated with affordability and cost. It was that in the only question that I saw that got a high response rate, it was, we want government to intervene to limit prices, even amongst Republicans. Now, that hasn't translated to the policymakers extraordinarily well. But if you look at the data points, that's almost the only example of both a problem and a policy intervention aligning with one another. I'm not saying that we know what that means in terms of policy application, but again, if you look through the whole survey, trying to find consistencies is one of the few areas in which there actually was a consistency.
This is one of those things where I think, you can go back to people who have been doing healthcare polling for 25, 30, 40 years, and it's generally been pretty consistent. The public is pretty consistent on this, which is basically, they don't want to pay more. They'd like someone else to figure it out. And any policy that looks like they're going to have some more personal responsibility to be a part of the solution, they resist to some degree. I will admit that that is a huge challenge for a market-driven approach. You cannot have a market-driven approach where everybody says, it's not my problem to figure out what the cost of something is. This is probably the main reason why these things go in fits and starts from a conservative perspective. It's very difficult to get traction because there's sort of a little bit of basic resistance to it. Having said all that, I don't think the surveys that are done of the public are going to give policymakers real clear guidance on anything. And this is one of those things where a bipartisan solution is going to have to be sold, and there's going to have to be leadership demonstrated. These things are quite complicated, and there are no simple fixes. It is not that easy just to say, you know what, why don't we just lower, the price of everything? Maybe that'll have no consequence. I kind of doubt it would have no consequence. So I think it's going to require political leadership that, from time to time, our leaders do rise to the occasion, and I think this is one of those where they're going to have to.
So there's a brand new concept sweeping the nation called evidence-based policymaking. Speaker Ryan and Senator Murray put together an evidence-based policy commission. I know some of you are chuckling because you think 240 years into this experiment we would have realized that was a good idea. But Senator, you talked about essentially efficacy and value. And one of the parts of the Affordable Care Act debate that I was most surprised about was how intense the debate was over whether or not we should actually try to inform decision-making based on evidence. And does anyone think that that is a debate that we might be able to revisit more productively? And reflections on why that went off the rails? Because I think to this room it probably seems like a reasonably obvious premise, but clearly politically it hasn't been. Chris is looking at his tie.
Well, I thought it was to Tom. And I'm looking for inspiration.
This is not a new question in healthcare. Some of you are old enough to remember the battle over back surgery when the data was made available in terms of the importance and relevance and appropriateness of certain back surgery, and guidelines were provided, and the reaction was quite rapid and quite hostile. I think there is this tension among providers, and I think the senator raised a very important point early on, and that is trying to understand what is value and the extent to which there is transparency in terms of how to make decisions. And if given information, will people make the right decisions? Will providers decide the right procedure, the right drug to use? Will the individual patient essentially choose the right direction in terms of the use of a particular provider? And I think there is value in that conversation. I think it has become increasingly important in terms of healthcare, in terms of understanding the value of guidelines, the value of best practices. And the challenge is engaging the provider community in coming to closure or agreement on what those strategies ought to be and what are best practices and how best to inform them. We have been reluctant to say to someone, you cannot have this, but will you be informed in terms of your decision making if we give you more information and if there is transparency about that information? But I think it is at the heart of moving our healthcare system is transparency, creation and understanding of value, the linkage of payment to value and to quality. And I think that's how we're going to have to move. But it is an enormously difficult thing to do. I mean, every ad on television that tells you to go out and, you'll be better if you take Viagra or whatever it happens to be, we have the most interesting process in this country of deciding what's best and going in and telling our physician or our nurse practitioner that's what we want. So it's understanding that decision-making and making sure there's transparency in decision-making that I think is going to be at the heart of making those transitions.
I've said it before, but I think it's really a key is measuring quality. Today it's the Wild West. We don't really have the capacity to measure quality universally, and that to me is going to continue to encumber our ability to base healthcare on evidence as we go forward. The other is interoperability. We still aren't an interoperable system, and because of interoperability challenges, we aren't able to share whatever evidence we have as we relate to particular cases or patients, as well as the system or the collage of subsystems we're working in. So those encumbrances architecturally are going to have to be addressed.
So I have a handful of other questions, but I'd like to pause. We have some fleet-footed mic runners. If you just would raise your hand, identify yourself, and we will take them as they come.
I'm Dr. Caroline Poplin. I'm a primary care physician. This is really for Mr. Capretta, but maybe the whole panel. Isn't the whole point of a market that different people value different things? And a market is an opportunity for people to select what they value and to deselect something else. I mean, when you have a whole line of cars, they offer different qualities and they're different prices. You can see what they are, which is harder to see in medicine. But some people want speed and performance, some people want economy, some people want fuel economy. We can't determine value in the abstract, even for a car. It has to be safe.
Well, I certainly agree that a big element of a market-driven system is the consumer selecting things that appeal to their preferences more than the other options that are available. I think in healthcare, obviously a challenge of a market-driven health system, a fundamental challenge really is the asymmetric information between the provider of the service and the consumer. And that can be overcome in certain circumstances, but it is a challenge. And so that has to be addressed as part of the sort of regulatory structure that goes along with it. But I take your point, and I think that that is an element of our system today. It's not done very well, as Senator Dashles, I think, described well. We have a collage of subsystems, some of which work pretty well, and some of which don't, and they're all kind of under a framework that isn't totally coherent. And so part of the challenge, I think, for this group, our group, is to put a little more definition on some coherence that might have some enduring value and allow that kind of consumer preference choice to work better in the future.
Well, one of the big challenges we face, I think, is the lack of transparency. We've all addressed it. I mean, it's pretty hard to have a market-driven system where there is such opaqueness around so many of the fundamentals in the market. I've asserted, and no one's ever challenged me, that healthcare is the only sector of the economy where at the time of purchase we don't know what it's going to cost or who's going to pay. And the lack of transparency undermines the capacity for meaningful consumer choice.
We have a question right here, and then we'll come to you, sir.
So my name is Emily Moss, and I'm a Master's of Public Health student at the University of Arizona. One big issue that I have with how this panel is talking about costs is that it's all on the consumers. And one thing that you guys see reflected in policy is that consumers don't want it to be on them. So what are some solutions aside that we could do as a system to control costs that are not on consumers, and what do you think that could look like in a bipartisan way?
That's a great question.
Well, I'd just say that trying to collapse your question into what we've just heard in terms of some of the data points, which is, I think, and even in this first question, I think instinctively people would like to have information sufficient to make good, thoughtful, informed, empowered decisions, which we never have done on quality, to Senator Dashle's point, quality or cost or anything else. So it's sort of, is that even a workable dynamic? But my takeaway is this, that and I'm interested in what you all think, because I'm just formulating this today. That the data shows that the public supports eliminating barriers to competition. So and there are major barriers to competition today. They support regulating excesses to market, or to regulating market excesses. Okay, so areas in which the market is taking actions that harm patients. And thirdly, where there are market failures, they support government intervention to be more aggressive. And I would suggest that means on excess pricing practices that competition isn't addressing. So, maybe that's an interesting takeaway. As it applies to policy development process to begin to empower this. But, I actually think that we too often don't talk about what consumers care about in terms of cost. We talk about federal costs, we talk about, employer costs, occasionally insurer costs, premium costs. The public cares about out-of-pocket costs. And we better make sure that our solutions and our interventions begin to address that problem, because otherwise we're talking past each other.
I just want to address the question just from a slightly different angle. I very much agree that our conversation is probably focused maybe too much on, what is the consumer role in all of this. It turns out, though, that in every health system, all the costs eventually make their way down to every consumer. So there's no entity out there that can pick up the cost of a national health system that doesn't involve taxpayers or consumers or citizens or something, okay? And so I think at the point of service, it's quite true that you could try to insulate the consumer so that their use of services is unrelated to their individual cost. And that would be more of a regulated system, obviously, where someone else is trying to control the cost, not through the consumer's use or decision making. And I think the public in some ways would be relieved if someone just came in and said, Medicare for all, so to speak. I think that's why it resonates. But then there are implications to that. You have to have taxes have to go up, which is another slide that says they don't want to pay the taxes either, okay? And there's great aversion in this country to taxes. So, our system of governance doesn't lend itself easily to, very big, massive changes unless we're in a crisis, which we hope we aren't in. And so, more likely, we're going to have incremental changes going forward, much like the Affordable Care Act was, despite what some people say, it was largely building on the existing infrastructure. And that was a big legislative item. So imagine what we do next. So I think I just would take a little bit of a point around, ultimately, everybody pays for this. And you could regulate the prices down and the cost could come down through a regulatory structure, but that has its own debating points as well.
I think the only thing I would add about cost is one of my most serious laments about the debate around cost is that oftentimes we fail to recognize the distinction between cost shifting and cost saving. There's too much cost shifting that goes on in the name of cost reduction, when we're not really reducing the cost at all. We're just shifting it on to somebody else. And we've just got to be cognizant of that inclination every time we talk about cost. More often than not, it ends up we're just shifting, and that's not solving the problem.
We have 3 questions in the queue, sir. You can start up, and then we'll move our way around.
Hi, my name is Harsha Prabhala, and I worked on the Hill and also worked in CMS with Cindy Mann. And I have a little bit of a long-winded sort of charge request and then an actual question. Senator Daschle had mentioned that there's going to be a lot of experimenting in states, which most likely will be inevitable, but I would respectfully sort of challenge the panel and BPC in general that the path of least resistance may not be the most optimal, in the sense that federal policymaking has goals and can accomplish mandates and standardization, which was sort of the undertones of the ACA. And as Senator Daschle mentioned and highlighted, there are 3 main things that were tried to be addressed, with cost, access, and quality. Access being the primary, cost being secondary, and quality obviously in there, but there were obvious sort of challenges to all 3, with the public option being pulled out. MIPS has faced a lot of sort of resistance, and on access there's been some rollback. So my sort of request would be, the RWJF's lion's share of their funding goes to sharing best practices among states, and I think there is a dearth of sort of thought leadership and level setting on what the floor is in terms of best practices, and some of the work that was just released on the sort of common understanding. But for cost, sort of for quality, for access, what are sort of minimum thresholds that states should allow? What actually defines a core benefit package for healthcare, so that states have at least some thought leadership and guardrails that can be used on the federal level? On the question, there's a sort of trend towards deregulation, both in a number of sectors, but also in healthcare. And I wanted to focus what are your thoughts on the impacts of deregulation, particularly on rehab clinics? There's been a large debate on opioid and mental health, as has been mentioned on the panel, but in Idaho, if you do not address adolescent care, you can open up a rehab clinic without any regulation. And then in Florida, there's no regulation whatsoever to open up a rehab clinic. And so when Tom McClellan was on national television with his issues with his son, he had no way of finding a legitimate or quality verified or any kind of ranking of a rehab clinic. And so your thoughts on deregulation broadly and also on mental health clinics.
Limits on flexibility, where would you pick that up?
Let me try and at least unbundle some of what you've asked about and comment on it. I think let's talk about mental health services and talk about some of the challenges that are being faced, particularly in the context of opioids and the availability of services. There is a complicated set of questions about those issues, about where services provided, by whom services provided, and under what circumstances. And I think people, in fact, BPC is we're having a day-long or an afternoon-long discussion today on this question of behavioral and mental health and what's available and what's not available. And there are issues that are federal in nature, and those may well be regulatory in terms of the review of the facilities. There are issues that are state-related, for example, scope of practice laws. There are the issues related to medication-assisted treatment and in what environment that occurs and by whom it can be provided and who is certified and under what circumstances. So I think what we're facing in this particular instance is a combination of federal and state strategies to try and address what is clearly an issue. The lack of resources that are available on a statewide basis, the lack of providers that are trained adequately, the lack of certification of qualified facilities and treatment areas in terms of adults and children. And I think it is that combination of questions that I think are being struggled with today that we don't yet have the answer to. You know, how do you determine what is a qualified clinic and for whom and under what circumstances? What do you happen in terms of people that in the judicial system, the Justice Department and folks that are being discharged from prisons, where there is a huge issue and whether they're treated inside but then can access services outside. A number of the states are struggling with this. Certainly up in the Northeast, there have been a lot of questions about how you integrate those services, but I think you've raised a series of questions that have not yet been addressed, but are in the midst of trying to be addressed literally at the state level as well as at the federal level, because it is such a complicated question.
I see a bunch of hands, so we're going to try to move through these questions. And
Michael Cook, I'm on the Virginia DMAS board and also have advised, I'm a health lawyer, but I've advised some campaigns in Virginia on health care over the years. One of the things that may help break some of the logjams is the Virginia experience. After the Senate, Virginia got itself on the Medicaid expansion into a box where, because of a whole lot of rhetoric, we'll forget why, how, or what, both sides have some blame, it became politically impossible to do the obvious. Thanks to the debate in Congress over the ACA this year, I think it educated the public on the difference between Obamacare and the ACA. And Virginia in the House lost a whole lot, the R's lost a whole lot of seats. The D's did something smart for a change. They got the lesson that give the other guy some cover. In other words, reach out to the other side. So we put in addition to the expansion, work requirements, which one could argue don't make a whole lot of sense in Medicaid, while they do make a lot, even if you believe they do in TANF. It was that compromise, giving the space, that made a whole lot of difference. And I think if whoever wins the elections, because they have major consequences, may get a lot more done if they turn around to the other guy and say, what do you need? And perhaps give a little bit in that. The second is just to emphasize what Sheila said, which is, if you've worked in the private sector, figure out what you want to get out of healthcare, and then put money behind that and not other things, because payment drives the product. Thanks.
those are great observations. And why don't we take a couple more questions and we'll try to get reactions. there's a nice cluster in the middle, very strategic of you, but we're going to go to the edge here for a little while, and then we'll come back, and that'll probably be all the time we have.
Hi, I'm Elizabeth Cullen with the Jewish Federations of North America. Hi, Sheila. So in looking at the chart of public opinion and costs, one question that I've always had is whether when you ask people if they're willing to pay more taxes for government-sponsored health care or things like that, do they understand, or even is it true, that they would actually be paying less because they wouldn't be having to pay for private coverage? I mean, how do the numbers fall out? Are they being asked to pay more for government sponsor when you consider the totality of dollars they're spending on health care?
I will note that we tried to get more sophisticated nuance into these questions than are usually tolerated by a polling firm. And I think that if you looked at the frame going in, I think there was some effort to try to have that kind of cause and effect. But fundamentally, I think the poll was designed around kind of a next political step. And so I think the way that people frame that question politically is, are you willing to pay more, for cost saving later? And I am dubious that the poll respondents thoughtfully integrated all of those questions into their response, but I think it is the political reaction that's the reality when we take these questions on. Question right there.
Blake Murphy, third-year medical student at Sturge School of Medicine at Loyola University in Chicago and health policy fellow at the AMA. What is your response to concerns that are raised about bipartisan solutions continuing to disadvantage minority and socioeconomically disadvantaged patient populations in these public policy solutions as opposed to health insurers and big pharma?
Well,
there's a.
Well, I mean, can I mean, I'm.
Take this on, Chris.
Maybe this is better for me to do it than I'll just say from my perspective, how do I say these things? First thing is, look at the Children's Health Insurance Program. Bipartisan achievement, substantial expansion of coverage for children. I don't think many of the advocates of children would say we shouldn't have done that because it wasn't a Medicaid expansion pure. It was it was a compromise. Okay, I mean, so now if you are saying, does that bipartisan achievement mean that you can't go as far as one party would want? Absolutely. But I will also say, and I'll say this about my party too, is that sometimes the perception that one party is willing to go further on things like cost containment caucus related issues that you could argue do or do not hurt people of color, which I would disagree with that. But to the extent to which people haven't gone as far, the Democrats are part of that problem as well as Republicans. And so I really hesitate. I always wonder sometimes how people would say, if incremental reforms that expand coverage that disproportionately benefit the people of color, and you could say, for example, the Affordable Care Act was one of them, and I would argue it was full of bipartisan policies. Not to do that would be actually an immoral thing, because you would be leaving so many people without coverage in this country. So I guess I disagree with the construct that all bipartisan achievements by definition in any way target unfairly people of color, because frankly, I get frustrated because we don't make any progress for those populations. So to me, it's an anything versus something, and it's frequently people who people who have health care are the ones who are opposing the coverage expansions in the first place.
Let me just add a couple of notes of a similar tone as Chris's. One, there's also bipartisan support for the community health centers and has been. and the continued availability and acknowledgement of the important role that they play in many communities that have an absence of a lot of clinical facilities, I think has been enormously important. I think there's also been growing recognition of the importance of research with respect to populations and the differential impact on populations of color in terms of availability of services and documenting the utilization of services. We're learning a great deal from a number of the private foundations, the Commonwealth Fund and others, certainly RWJ, who have looked at these issues and have in fact led to policies being made that essentially relook at essentially the directions that we're giving in terms of the service delivery. The history of the DISH program was to acknowledge that hospitals that are in communities that serve a large number of individuals who are low income and people of color need additional support. And we've revisited that question now because of the absence of expansion in some communities where we expected that population would be cared for as a result of the expansion. Where it hasn't happened, questions have been raised now about whether or not we ought to continue DISH and in what role DISH ought to play. And the whole history of the financing of large public institutions in low-income communities is one that we also struggle with. So I think your point, which is there needs to be particular attention to that population, is absolutely true. We are increasingly documented the variation in terms of treatment and access and utilization of services. And so it's something that we have to continue to pay attention to, but I would argue that it's not something that has been ignored, perhaps not dealt with as thoroughly as it might have, but I think all of these pieces reflect the nature of the services, where they're provided, by whom they're provided, and to whom they're provided, and what that financing structure looks like. So it's the history of CHIP, it's the history of the community health centers, it's really a variety of those programs.
We have time for a final question, and gentleman, his hand up, I guess, is our last. Yeah, please, sir, the microphone's right there.
It's always intimidating to be the final questioner.
Yeah, better be good.
Woody Kessel, I'm a pediatrician. And I guess my question is going to be addressed to both Sheila and Chris. Health financing involves almost an infinite number of options, lots of thinking. Receipt of quality health care is not optional, particularly for children. The history of CHIP was indeed bipartisan with Senator Kennedy and Senator Hatch. It was vetoed, the reauthorization was vetoed twice by President Bush. This is children. The reauthorization took an extended period of time, was highly charged politically, was finally reauthorized, frankly extended for 10 years, which is good. But now its financing is in jeopardy. So I guess I'm puzzled how we proceed even around a bipartisan issue like children.
Okay, well, I just happened yesterday to be at a conference of children's advocates, and within a Republican Congress and a Republican White House, the Children's Health Insurance Program was reauthorized for a full decade, which is almost unheard of, and probably Jim would say that's crazy, 10 years, and with actually relatively limited alterations to the underlying law. Maybe we may be staring at that from two different perspectives, but I think that is actually extraordinary. Where I think the biggest threat to CHIP is not the CHIP reauthorization, is the constant focus on Medicaid and cutting Medicaid, which serves as the fundamental foundation of the Children's Health Insurance Program. So if I was using your example, I would more focus on the Medicaid program than I'd focus on CHIP. But I take your point.
And I do as well, and I think part of what caught CHIP up, which is something Senator Daschle has touched on, we've all touched on in different ways, is that some of these issues get obscured by other issues. And I think a lot of the resistance around the timing of the CHIP reauthorization and the debate around CHIP was also caught up in broader politics. just as the VA bill was recently caught up with a set of different issues and the Labor H bill is being caught up in a different set of issues. The politics of the moment sometimes drive decisions in terms of timing and the reauthorization of programs, which is unrelated to what is understood to be the value of the program. Senator Hatch has never stepped back from his commitment to the CHIP program. I think the Republicans on the HELP committee and others have been quite strong, as have obviously the Democrats. So I think part of it, we have to separate it from the environment in which it was occurring. And I think it was less a function of an opposition to the support for the program than it was about the politics of a variety of other topics. But your point's a good one, and Chris's point is a very good one, which is I think the more fundamental threat is the Medicaid threat that I think is really the building block upon which CHIP was built.
Tom or Jim, a final thought before we close down?
Yes. Well, first of all, I think this has been just an excellent dialogue. I'm oftentimes asked if I'm pessimistic or optimistic about all of this, and frankly, I'm optimistic. I really think that the requirements of our country and the need to address this issue isn't going to go away. And as I talk to people who are running for Congress from all over the country right now, I'm amazed at the degree to which they've already done their homework and the degree to which they're engaged and asking a lot of the right questions about public policy. So I don't think this issue is going to go away. I think you're going to see a lot of new talent and new ideas and maybe new energy as the next wave of new members of Congress, both Republican and Democratic, come to Washington. So I'm expecting some good things to come.
All right, Jim. I'm not going to let you say anything, Jim, because you can't kind of not take advantage of that as a wonderful closing thought. Before I ask you to join me in thanking our panelists, I also just want to acknowledge Natalie Weiner and Emily Schroeder, who helped put all of this together, as well as Matthew McKern, Ashley Ridlin, and Joanne Donnellan, who worked with Bill and Catherine to lead our health work. And so maybe a round of applause for the entire team. And I'm told it's pouring outside. I'm just kidding. I have no idea what it's like outside, but hopefully you did bring umbrellas. Thank you for joining us, and we'll be in touch.